Assalamu alaikum, Mustafa.
Good morning,
Morning.
Mr. Chairman. Good morning, colleagues. Thank you for the nice invitation. So the definition of monovision is a corrective measure for dealing with presbyopia, making one eye for perfect for distant vision, the other eye perfect for near vision. So we have to know what is the dominant eye. So ocular dominance, it's a dominant eye when your brain relies more on one eye over the other. So dominant eye does not always have better vision. This is very important than your non-dominant eye. So what are the types of dominance? There is different types, motor dominance, which referred to in this talk, sensory dominance and acuity dominance. How to test for dominance? There are many clinical tests. And also we have to know stereopsis. Stereopsis is the visual ability to perceive the world in 3 dimensions, length, width, and depth, which then allow the person to judge where an object is relative to him or her. There is different degrees. How to test? There is many clinical tests. So the advantage of monovision, it restores ability to focus on objects that are up close without giving nearsightedness in both eyes. The disadvantage is some patients will have trouble adapting to the change. It may take weeks to months to adapt, and the development of aphanopia. Also, there is a good chance to develop loss of depth and contrast perception and a Pelfrey effect, which is a neuro-ophthalmic observation in which 2-dimensional objects are perceived to be 3-dimensional due to slight discrepancies in signal transmission time between the 2 eyes. So how to select the patient for this? We have the patient should have a strong desire for spectacle independence. They have to comprehend exactly the implication and limitation. And poor candidates are patients with strong ocular dominance and also patients with exudation greater than 10 diopters. So patient with mild to moderate myopia, this is very important. We have to discuss this with them, and we give them a trial with a contact lens. So how much anisometropia? This is a debate. A lot of studies has been discussing this. It ranges from the standard is up to -2 diopters, and there is different types in the range of anisometropia. So if a patient desires to use only computer or intermediate vision, it's better to the anisometropy to be around -1 diopter. If individual requires excellent close vision for reading, it's better to be -2. So monovision can be employed, as we said, we saw before, different types with contact lenses, refractive vision correction, and intraocular lenses. The contact lenses is from very long ago. You use one lens for distant and the other for near. And a review of literature, the patient satisfaction is about 50 to 75%, which that means that a good number of patients are not satisfied. If you are going to refractive surgery, it's laser or PRK, there is better tolerance than the contact lenses due to improved binocular adaptation, less residual anisoconia, and of course the discomfort of the contact lens. So patient selection is important. Age, of course, patient reaching presbyopia, 40s or more. The occupation is very important. We have to give them a contact lens trial, which is not really a real word acceptance of the patient, and the refraction, myopia versus hyperopia, and the target refraction, the dominant eye stereo acuity, as we said. So the success rate for monovision in refractive laser correction range from 72 to 90%. Factors related to better results is a good interocular blur suppression, post-treatment anisometropia, and successful distant correction fully for the dominant eye, a good stereo acuity. The myopic eye in monovision is better than the hyperopic eye. Why? Because monovision and hyperopic eyes add to the overall laser correction requires more tissue removal, and may add to the unpredictability of the outcome. We know all the refractive cataract surgery. We changed the IOL, and this is different types of premium IOLs. Each one of it has its own disadvantage. In monovision, a larger degree of anisometropia is needed. For extent, this is the standard. So the success rate increases the more the patient is older. So over 70 years, it may have a very good result. Pseudophakic monovision, of course, we use a monofocal IOLs in the dominant eye, and in the other eye, we use also a monofocal, but in the range with less, we target myopia about minus 1.5 diopter to 2.5 diopters. So the advantages over multifocal and ADOF. Limited this photopias. Monofocal are not sensitive to residual astigmatism and posterior capsule opacification as premium lenses. They can be used in eyes with borderline corneal and macular pathology. So what are the types of monovision? We have mild monovision, which sometimes say it's many monovision. This method maintains contrast sensitivity, causes less anisometropia. In our experience, at least 90% of our patients were satisfied. There is another type, which we call it hybrid monovision. In this, a monofocal IOL is inserted in the dominant eye, a diffractive multifocal eye in the non-dominant eye. With this type of binocular vision, patients do not complain of discomfort. More than 80% are satisfied. However, the normal range of stereopsis was little bit affected, but it was in the same range. Customized monovision, where we target refraction is emmetropia in the dominant eye and a slight myopia in the non-dominant eye. In comparison with pseudophakic monofocal or standard monovision, this strategy achieves the same effect as a standard monovision. Near stereopsis is typically within the normal range. Contrast sensitivity is likely to decrease, and the ability to read very small characters is diminished. Which lens model? Of course, mixing and matching in presbyopic correcting lenses was very common practice. For monovision, we can do this also. How we can do this? Conventional monovision is set for less than or equal to minus 1.5 diopter, or somewhere between -1 and -2. Many monovisions allow a maximum of -75 anisometropia, or between -1/4 or -3/4. Conventional monovision aims for far and near vision, while many monovision the focus is on intermediate vision, and this is what we call a blended vision. So which lens model? Many study was done that we know that the spherical IOLs the normal spherical IOLs add to the positive aberration made by the cornea. And using IOL, this was the trend. Just have a minute. Okay. There was a study by Rock and colleagues that using in the dominant eye a spheric IOL and the non-dominant eye spherical IOL increase the depth of field. It does not advance. Huh? Okay, so the lens, it's better to use in the distant eye a spheric IOL and in the near eye spherical eye. In conclusion, good candidates for monovision include high motivated patient, avoid patient with history of strabismus, pseudophakic monovision that we use in the distant eye, as I told you, give full emmetropic, and in the near eye we can aim to the mild vision. So this is how the patient will see. The one eye is perfect for near and one for the odd, and the blended vision that he can see without glasses with both eyes. Thank you. Great, thank you.